Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Healthcare Unfiltered Express, we have Amer Zeidan from Yale University coming live from Lisbon. Are you watching soccer? What are you doing there?
Oh, I wish actually. We are actually in the middle of the International Consortium for MDS meeting. It's an annual meeting where we discuss everything related to MDS. This is a meeting that I organize basically every year, and we have experts coming from across the world, really, from Europe and US primarily. But this is very timely. Unfortunate kind of development with on the high-risk MDS front, but we try to learn lessons from what happened and see ways to improve in the future.
All right, so I got you here on Healthcare Unfiltered Express. Talk about VERONA. We saw a press release. VERONA study was negative. Everybody was anticipating what it is. Tell us what is the VERONA study and what you learned from the press release so far.
Perfect, yes. However, I just want to congratulate you first on the 6th anniversary for the podcast. It's really, I think, one of the best podcasts out there. So VERONA was a very highly anticipated study for your audience who don't follow the space very closely. The standard of care in high-risk MDS has been single-agent hypomethylating therapy with azacitidine, or an oral version of decitabine called decitabine sidazolidine or Dixi. This monotherapy approach has not really changed in the last 20 years, and multiple drugs have tried to add in a drug on top of the HMA monotherapy, with several studies showing positive data in the phase 1 and 2 setting. And once you go to a randomized phase 2 and phase 3 setting, they have been all negative for the primary endpoint. And the last man standing was actually the VERONA trial. This was the only fully completed trial in which patients were randomized to receive azacitidine with placebo versus azacitidine with venetoclax, and the trial has been accrued actually quite for some time, and we were anticipating results for a long time now. But unfortunately, a few days ago, there was a press release just indicating that the primary endpoint, which is overall survival, was not met. And in that press release, actually, the hazards ratio was also included, which was, I believe, 0.93 or something like that. So it's a very kind of negative trial for the primary endpoint. This is clearly very disappointing because I think venetoclax is a drug that many of us think should work at least in a subgroup of patients with MDS, because it's already approved and works in older patients with AML who are unfit for intensive chemotherapy based on the VIALE-A trial, and it's widely used. Actually, ahead of VERONA, many people were already using venetoclax in many MDS patients, whether in the front line or the second line setting. So I think we still need to see the full results of VERONA to understand several things. One of them is what really was the cause of this negative result. Was there imbalance in early mortality, or was there imbalance in some of the baseline characteristics? Also to understand, I think importantly, whether it worked in subgroups of patients. For example, I think many of us think that venetoclax works well when you have a lot of blast, basically when you are closer to AML. And this is actually has been renamed MDS/AML when you have 10 to 19% blast by the ICC classification. So it would be very interesting to see subgroup analysis for those patients. But the other, I think, big group is the patients who went to transplant, because there has been data that maybe more aggressive cytoreduction with aza-ven might help patients who go to transplant achieve better results. So I think there is a lot to understand and dissect from this trial, which the press release has indicated will be presented in a meeting in the near future.
Probably will be either ASH or EHA or something like that. Let me ask you this. You mentioned something really important. You said that a lot of people have been using venetoclax even ahead of VERONA. The VERONA study is negative. You're waiting for additional results. Do you think that practice pattern in the real world might change, or do you think people say, okay, I understand this trial, but I had a couple of patients who did exceptionally well. I'm going to keep using venetoclax where I can. How do you think this will translate into real world practices?
Yeah, I think that's a good question. I think for patients who, I will talk about my own kind of approach and then I guess comment on what I think people are doing. So I generally actually have been waiting for Verona before I adopted the approach of giving venetoclax in a large segment of patients. I have been only restricting venetoclax in my own approach to relatively younger patients who I otherwise would have given intensive chemotherapy to. And some patients with high-risk MDS, we give intensive chemo as a bridge to transplant. So this is a relatively small subset of patients, not more than 10 to 20%. And the idea is that you're giving the azacitidine as a very short-term combo for, 2, 3 cycles and then get them to transplant. What was not very clear to me is for patients who do not go to transplant, is there a benefit from chronic therapy? And for patients who have less than 10% blast, is there a benefit of a therapy without being bridged to transplant? And I don't think from the press release, you really have an answer on either one of those questions. So the short-term answer is my own practice is not changing based on the press release. I'll still give azacitidine in some patients with excess blast as a bridge to transplant because otherwise I would be giving them intensive chemo or sometimes they might need many cycles of AZA before they are cytoreduced in an efficient fashion. We certainly know that adding venetoclax to AZA does cytoreduction effectively. I think in the community, it's going to be very interesting because we also have data in the refractory setting and we don't really have approved drugs aside of HMAs in high-risk MDS, with the exception of an IDH1 inhibitor, ivosidenib, which applies to less than 5% of patients because only this number of patients have an IDH1 mutation. So I think people are probably still going to use it as a salvage therapy or still continue to use it on the front line until we see the full kind of context of data.
Last question, Healthcare Unfiltered Express. It's an express edition, What's next for high-risk MDS?
Yeah, I mean, I think there are a number of agents that are being kind of studied in the space, in phase 1 and phase 2 trials. There are 2 drugs that are in advanced phase 2 testing. One is actually an anti-CD47 called AK117. And this is an anti-CD47 agent that's different from magrolimab in the sense that it does not cause the anemia that was seen with magrolimab because the way it's designed, it does not lead to hemagglutination. And the early data from China have suggested actually a CR close to 40 to 50% in the frontline setting, which is higher than what you would think with monotherapy. But again, you have to be realistic given we have seen similar early data that did not translate in subsequent bigger trials. So there's an ongoing randomized phase 2 trial with this drug, which hopefully will report soon. And then there's another immune checkpoint inhibitor called bexmarilimab, which is an anti-cleaver-1. Cleaver-1 is a receptor that's expressed on macrophages, and it's actually similar to the CD47 pathway. Basically affects the ability of the macrophages to clear the tumor cells. And Cleaver-1 has been overexpressed in MDS and AML, and inhibiting it has been associated with immune activation of the macrophages as well as the adaptive immune system. Early data presented in ASH and EHA from the phase 1 study, again, suggested synergistic activity with azacitidine. And there is discussion about taking this to a phase 3 trial in pending discussion with the authorities. And lastly, there's actually second generation PCL2 inhibitors that are already being tested in phase 1 and phase 2, but one of them actually called lisapetoclax. This drug is actually already in a phase 3 trial. My concern is that this trial seems like, according to clinicaltrial.gov, to have a very similar design to VERONA in terms of overall survival as the primary endpoint, and a 400-something patient, 14 days of this drug, which is similar to venetoclax in MDS. So I have some concerns about how different is this drug from venetoclax. There is some data to suggest that it might work a little bit better and even in some cases of ven resistance, but I think it's very limited data. So I don't have very high confidence based on what is kind of publicly known about this drug. But there are a lot of other drugs that are being studied in phase 1 and phase 2, and hopefully we're going to have something that will, take us off this, what I call the boulevard of broken dreams. We need to get this off this boulevard, similar to what happened with AML. AML until 2017, no drugs, and then in 7 years we have 14 new drugs. So I'm hoping same will happen high-risk MDS, and on a optimistic note, this already has happened in lower risk MDS where we did not have drugs for a long time, and now we have luspatercept and imetelstat and a number of other drugs being studied as well.
Well, we will stay tuned for these drugs. Dr. Amer Zeidan from Yale University coming to us from Lisbon on Healthcare Unfiltered Express, talking VERONA and high-risk MDS. Thank you so much.
Thank you so much, Shadi, for having me.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.